Hello my dear students, welcome on this session. On the previous session, we are doing hematopoietic system, and on the previous session, we started discussing anticoagulant drugs. We compared heparin and warfarin sodium as far as all the aspects are concerned, the mechanism of action, the adverse effects, everything. We also discussed the indications, that's the uses for heparin and warfarin sodium. So I would advise you to go back to that session to get these details. And from there, we continue. We continue with the drug interactions of oral anticoagulants, that's warfarin. As you know, heparin has less drug interactions. Warfarin has got many drug interactions. So, we are doing it separately. What are the drug interactions for oral anticoagulants, especially warfarin? First, we will consider those interactions in which there is increased effect of warfarin, that's excess anticoagulant effect leading to bleeding. So all those drugs who will be making the warfarin more prone to have its effect are going to produce bleeding. Number one top candidate is aspirin. Aspirin has got antiplatelet effect, and that's why this is going to lead to bleeding. Plus warfarin, there will be more bleeding. Antiplatelet effect is the first reason. The second one is decrease in the prothrombin, and the third one is the plasma protein binding displacement. That's another reason. Next, the situations with decreased vitamin K, that's the antibiotics which are going to eradicate some microorganisms in the intestine, the colonic bacteria, and therefore vitamin K synthesis will be less. In these situations, you can get increased effect. Next, decreases the prothrombin, for example, cephalosporins. Cephalosporins decrease the prothrombin, and this makes the patient more susceptible to bleeding if the patient is receiving warfarin. Next, all those drugs who are displacing warfarin from the plasma protein binding sites, then the warfarin will be more in the blood in the free form and its level will be more. So this will lead to bleeding. For example, NSAIDs, long-acting sulfur drugs, and phenytoin. And all those drugs who are inhibitors of hepatic microsomal enzyme system, or what you call cytochrome P450 enzyme system, they are going to inhibit the metabolism of warfarin. So warfarin levels will be high and there will be bleeding. HMES inhibitors, as you know, is erythromycin, chloramphenicol, cimetidine, amiodurone, metronidazole, and the azole antifungals. All these substances can increase the bleeding due to warfarin. Now we come to opposite. Who are the ones who are going to decrease the effect of warfarin? Inducers, who are going to increase the metabolism of warfarin. Obviously, barbiturates, rifampin, griseofulvine, these substances will be producing decreased effect by increasing the breakdown of warfarin. Oral contraceptive pills, that's the estrogen progestin pills, they increase the blood levels of clotting factors, and this is why they can also have opposite effect, and naturally there will be decreased effect of warfarin. So this is regarding some important drug interactions. It's essential to remember the drug interactions because warfarin is a highly plasma protein binding agent, number one. Secondly, there are many agents which interfere with either vitamin K synthesis, or there are agents which affect the prothrombin synthesis or have got antiplatelet effect. All these are going to interact. If you remember, on the last session we discussed about heparin, and on this session we are going to discuss the low molecular weight heparins. Low molecular weight or fractionated heparins, the molecular weight is between 3000 and 7000. There is enoxaparin in this group, dalteparin, riviparin, nidroparin. Why I am discussing them separately? How they are different, the low molecular weight or fractionated heparins. They have more selective action on factor 10A, more selective action on factor 10A, and less action on thrombin, that's the factor 2A. That's the most important reason. The selectivity of the action is on 10A and they are not concentrating on thrombin. They produce a conformational change in antithrombin 3, so they have less effect on activated partial thromboplastin time and the whole blood clotting time. So that's great. APTT and the whole blood clotting time, there is less effect. They also have less antiplatelet effect as compared to heparin. So there is less thrombocytopenia and there are less hemorrhagic complications. That's the bleeding. The bleeding complications are less. So I hope you are appreciating the advantages and how they are different. And please remember the keyword selective action on factor 10A and less action on factor 2A, that is thrombin. I take you to the next slide. Low molecular weight or fractionated heparins have also got more bioavailability on subcutaneous route of administration and they have got a longer half-life. That's a great advantage of these agents. And you can give them once a day or twice a day by subcutaneous route of administration for prophylaxis as well as treatment. So more bioavailability, longer half-life is possible to inject just once a day or twice a day. And there is a more predictable response. So you don't have to have stringent requirements for monitoring which you have to do with heparin. So the response is more predictable. Next, their clearance is dose dependent. So simply you can calculate the dose based on the body weight of the patient. So dose calculation on simple weight basis is possible because the clearance is dose dependent. Are you seeing some advantages, some great advantages? More bioavailability, longer half-life. You can just give it once or twice a day. Response is predictable. Too much of stringent monitoring requirements are cut down. And because the clearance is dose dependent, you can simply calculate the dose on the basis of body weight. In addition to this, we already said the thrombocytopenia, there is lower risk of thrombocytopenia and it's safer than heparin for long-term as well as short-term administration. One more adverse effect of heparin is osteoporosis, and LMW, that's low molecular weight or fractionated heparins, have shown a lower risk of osteoporosis. Where to use them? Again, the same situations, same conditions where we use heparin. For prophylaxis, most important is venous thromboembolism, that's DVT, plus pulmonary embolism, post-operative and post-stroke. For treatment of, again, DVT and unstable angina or maintaining the patency of cannulae and shunts. So that's about the low molecular weight or fractionated heparins. Next we do a small slide on direct thrombin inhibitors. Who are the substances who can directly inhibit thrombin? And these will be useful for heparin-induced thrombocytopenia. One is hirudin, second one is lepirudin, and you have argatroban, megagatran, and zimelagatran. I just mentioned about lepirudin if you remember in the last session. So direct thrombin inhibitors are useful for heparin-induced thrombocytopenia. So that's about the anticoagulants, heparin, warfarin, and the thrombin inhibitors. Now the topic is changing. We are going to a kind of opposite substance, and that's vitamin K. So this is going to be useful for bleeding disorders. Until now we were talking about management of clotting, management of coagulation. Now we are going to the opposite phenomenon, that's the bleeding disorders, and most important substance useful is vitamin K, and there are plasma fractions which can be used. Vitamin K is a fat soluble vitamin, and please mind well, it's synthesized in human beings. It's synthesized in human beings by colonic bacteria, and they need the bile salts for absorption. What are the substances exogenously which can give vitamin K? Is green leaves, cabbage, spinach, and cheese. Apart from this, you have liver. And vitamin K is important because it's cofactor in the stages of coagulation, especially factor 2, 7, 9, 10. 2 is prothrombin and factor 7, 9, 10. And if vitamin K is less, if there's vitamin K deficiency, this is going to lead to bleeding. Hematuria, ecchymosis, gastrointestinal bleeding, nosebleed, all these will be evident. So what are going to be the uses of vitamin K? Number one, the most common use is the situations of bleeding, especially due to the overdose of the oral anticoagulant drugs. So if the patient is on oral anticoagulants and if there's toxicity and there's bleeding, the drug of choice is vitamin K. Stop the oral anticoagulant and give phytonadione. That's the most commonly used form, vitamin K1 oxide. Then the patients who are on prolonged hospital stay, ICU stay, and the patients who are on parenteral nutrition, because these patients are likely to have vitamin K deficiency. Next, prolonged antimicrobial therapy. This is one of the important reasons, because the antibiotics, antimicrobial agents are going to destroy the colonic bacteria. So the synthesis of vitamin K by the colonic bacteria is going to be reduced. So prolonged antimicrobial therapy. Then conditions like obstructive jaundice and malabsorption, that's tropical sprue, regional enteritis. Liver diseases, liver cirrhosis and viral hepatitis. And lastly, the newborn and premature infants, they might be deficient in vitamin K because their intestines don't have any bacteria right now. So newborns and premature infants, and these patients might need phytonadione, that's vitamin K, 1 milligram by intramuscular route of administration. Please remember, the dietary deficiency of vitamin K is rare. This is not the reason of vitamin K deficiency. We have seen what are the reasons. It could be overdose of the anticoagulant drug, or the patients who are staying for a long time in the hospital, ICU, or who are on parenteral nutrition, or receiving antimicrobial treatments for a long time, or the hepatic disorders including obstructive jaundice, liver diseases and malabsorption states, and newborns and the premature infants. So that's about vitamin K. Let's move on to see what are the plasma fractions which are available. There's factor 8 for hemophilia, factor 9 for Christmas disease, that's hemophilia B, desmopressin acetate given intranasally to activate the factor 8 in Christmas disease. Then plasma concentrates with prothrombin, factor 8, 9 and 10. All these are the plasma fractions which could be used in certain. I'll keep the slide for a few seconds so that you can have a look at this and revise yourself. Factor 8, hemophilia A, factor 9, Christmas disease, desmopressin acetate intranasally to activate the factor 8, and the plasma concentrates with prothrombin, factor 8, 9, 10. So let's move on to the next slide. That's the drugs used to promote clotting. So this is another way, drugs that inhibit the fibrinolysis and promote clotting. So they will be useful in certain situations to take care of the bleeding. The first commonly used drugs is epsilon aminocaproic acid, that's EACA. Next one is tranexamic acid, and the third one is aprotinin, which is a serine protease inhibitor. Please remember EACA, epsilon aminocaproic acid, tranexamic acid and aprotinin, and look at the indications in which they might be useful to promote clotting. Number 1, hemophilia. Number 2, the bleeding due to the surgery or after the surgery. Bleeding from prostate or urinary bladder is very important indication. You need to stop it emergently. Then bleeding during the open heart surgeries. Then coronary artery bypass graft, that's CABG, and sometimes in patients with menorrhagia. So these are the indications for the agents who promote clotting. The next important issue in the blood is you tried your anticoagulants and everything, but finally the thrombus is formed. And what to do then? Now you need to lyse the thrombus. You need to produce a thrombolytic effect, or you want to dissolve the thrombus, and this could be life-saving in certain situations. So we go on to discuss what is thrombolytic therapy. As you know, plasminogen is a protein which gets converted to plasmin, profibrinolysin to fibrinolysin, and this particular plasmin is thrombolytic. It cuts the fibrin strand. So for cutting the fibrin strand, you require plasmin. This plasmin comes from plasminogen. Plasminogen has to be activated, and then you are going to get the formation of plasmin. So plasmin is the thrombolytic. Plasmin dissolves the clot and produces reperfusion of the occluded vessel. So we need to use the substances who can activate plasminogen. So we need plasminogen activators. So I hope you heard the word TPA. T stands for tissue, and that capital P and A is plasminogen activator. If you ask a question, this TPA combines with which particular protein? Don't get fumbled. It has to combine with plasminogen and it has to activate plasmin. So you have streptokinase, urokinase, these are plasminogen activators. You have recombinant tissue plasminogen activators, that's TPA, including alteplase, reteplase and tenecteplase, and these are extremely useful after myocardial infarction where there is coronary artery thrombosis. Dissolving this clot is crucial and it's life-saving. Then it's useful for pulmonary thrombosis, it's useful in deep vein thrombosis, DVT, and it's useful in stroke for dissolution of the clot. So we are calling it the thrombolytic agents. For example, let's see the drug and their T-half, that's the half-life. Urokinase, half-life 16 minutes. Streptokinase, half-life is 20 to 80 minutes, on an average 23 to 24 minutes. And TPA, namely alteplase, reteplase, have got a short half-life, that's only 5 minutes. Reteplase, tenecteplase are the modified tissue plasminogen activator, and they have the longest action, and that's why they are called longest acting bolus fibrinolytics. They are used intravenously or by intracoronary infusion, and they are going to decrease the mortality and they are going to improve the cardiac function. Obviously, I hope you understand they are more effective if given as early as possible, preferably within 3 hours, and if you give within 12 hours, the mortality reduction comes down. The mortality reduction is about 10% if you give within 12 hours of the thrombus formation. If you give early, within 3 hours, the mortality can be prevented and it's really going to be useful. Streptokinase and TPA, that's tissue plasminogen activator, the newer ones, have got comparable efficacy, and the difference is the streptokinase acts on the fibrin bound as well as the circulating plasminogen. So it's going to produce its effect on the plasminogen which is circulating in the blood plus which is bound to the fibrin. Whereas the rest of the drugs, whatever newer drugs we said, tissue plasminogen activator, they are more selective for fibrin bound plasminogen. It means they are going to target the thrombus, not the plasminogen which is circulating. So that's more selective action. They are going to be selective for fibrin bound plasminogen in the thrombus, and this is why we prefer the newer thrombolytic agents. What will be the adverse effect of thrombolytics? That's dissolving the clot or dissolution of the clot. Yes, it will be opposite. It will be serious bleeding. Can have gastrointestinal or intracranial bleeding. Some agents can produce anaphylactic reactions or delayed hypersensitivity reactions. Example is streptokinase, which is obtained from bacterium, that's beta hemolytic streptococci, and this is why it could be antigenic. Urokinase is obtained from human urine, so you don't expect any hypersensitivity reactions. Number 3, there can be precipitation of arrhythmia on reperfusion of the occluded vessel. So once you remove the thrombus and the occluded vessel gets reperfused, it can lead to arrhythmia. So these are the 3 adverse effects of thrombolytics, important ones. Contraindications, obviously, if the person has an internal bleeding or hemorrhagic stroke, you can't give thrombolytic agents. If there is recent intracranial or intraspinal trauma, this might be liable to bleeding, so you can't use. You can't use in the patients who underwent recent surgery or who are the patients with known bleeding diathesis. You can't use it because you already know this patient has a bleeding diathesis, and patients with severe hypertension. There is a risk of bleeding. So thrombolytics are generally not used if there is bleeding diathesis or there is already internal bleeding or there is recent surgery, recent trauma, or if the patient suffers from severe hypertension. So we did anticoagulant agents, we did the agents which promote clotting, we discussed the thrombolytic therapy, and now we move on to something very important, that's antiplatelet drugs. Antiplatelet agents prevent platelet aggregation, and by this mechanism they prevent clotting. They are not acting on the coagulation mechanisms, coagulation factors, so we don't call them anticoagulants, we call them antiplatelet agents. Let's classify them. Number 1, thromboxane A2 synthesis inhibitors acting on the thromboxane A2 is low dose aspirin, very important. Next, drugs which inhibit the ADP binding, how do they act? They are antagonists of the GI couple P2YAC, or it's also called as P2Y12 type of purinergic receptor. So this is a purinergic receptor, it's a G protein coupled receptor, GI protein coupled, and the subtype is P2YAC. And this mediates the adenyl cyclase inhibition by ADP. So this is the receptor, they block this receptor. So we are calling it drugs inhibiting ADP binding. You have ticlopidine and clopidogrel. Next, you have the drugs which inhibit the GP2B3A receptor, the glycoprotein 2B3A receptor. So the drugs which block the GP2B3A receptor, you can call them GP2B3A antagonist. Example, apixaban, which is a monoclonal antibody to this receptor, and you also have eptifibatide and tirofiban in this group. So what I have done on this classification is I have just told you the major important antiplatelet drugs according to their mechanism of action. Let's revise. Thromboxane affecting thromboxane A2 is aspirin, low dose aspirin. Inhibiting ADP binding is ticlopidine and clopidogrel, and GP2B3A antagonist is apixaban, tirofiban and eptifibatide. There is one more drug which I am mentioning down separately, and that's dipyridamole, and it inhibits the phosphodiesterase 3 and increases the cyclic EMP, so it can potentiate the prostacyclin. So either you can inhibit the thromboxane A2 or you can potentiate the prostacyclin, that's PGI2. So dipyridamole potentiates the prostacyclin, and that is the way it produces anti-aggregatory action. So this dipyridamole is another antiplatelet agent, but I am not considering it under the major antiplatelet agent groups. For us, most important are TXA2 inhibitors, then inhibiting ADP binding, and GP2B3A antagonist. So that's the plan, and we're going to discuss further in details about these individual agents. Antiplatelet agents, they are indicated to prevent the platelet aggregation and clotting. You already said this. Look at the details. Low dose aspirin is useful for secondary and primary prevention of myocardial infarction. So many patients are on low dose aspirin either for secondary prevention or primary prevention of myocardial infarction. Next situation, the patient is now in myocardial infarction. He is in acute stage of myocardial infarction. Still, we give aspirin, and as far as possible a soluble or chewable aspirin tablet so that it can reach the circulation as early as possible. What's the purpose? This aspirin is given to halt the progression of the process which is going on inside. So if there's still platelet aggregation going on, then aspirin can go and halt the progression or slow the progression, and this ultimately can lead to decrease in the infarct size. So that's the purpose. So please remember, low dose aspirin for prophylaxis as well as during the acute attack of myocardial infarction. Next, drugs which inhibit the ADP binding are extremely useful if the patient is allergic to aspirin, or for any reason you cannot give aspirin to your patient. So this discussion makes it quite clear that in the antiplatelet drugs, aspirin is at the top. That's the most important candidate. If there is allergy to aspirin or you cannot give aspirin, you think of the drugs which inhibit the ADP binding. The first agent is ticlopidine, and ticlopidine leads to certain adverse effects. Please remember, I am not saying too many things about ticlopidine, so you can easily remember: neutropenia, idiopathic thrombocytopenic purpura, and bleeding. These are common adverse effects of ticlopidine, and there is an incidence of neutropenia with the use of ticlopidine. We have the second drug, clopidogrel, and clopidogrel has got less incidence of neutropenia. So first, aspirin. If aspirin cannot be used, then there are two agents. The first one is ticlopidine, but it leads to more neutropenia, and clopidogrel produces less neutropenia. So clopidogrel is preferred to ticlopidine because this has got less incidence of neutropenia. The next group on the list is drugs which inhibit GP2B3A receptor, glycoprotein 2B3A receptor. And we already said the names: apixaban, eptifibatide, and tirofiban. This GP2B3A receptor is required for the action of fibrinogen. Unless GP2B3A receptor is there, fibrinogen cannot act. I hope you will remember this much. So apixaban and eptifibatide and tirofiban are GP2B3A antagonists, and by blocking the GP2B3A receptor, ultimately they are going to block the action of fibrinogen, and this is how they are going to lead to the antiplatelet effect. They are extremely valuable in patients with acute coronary syndrome to save the life. They are the patients in which there is imminent myocardial infarction and you need to do something very emergently, and apixaban can come to your help, and it produces antiplatelet effect and is useful for acute coronary syndrome. So just have an overview. Antiplatelet agents are major drug which is used is aspirin. If aspirin cannot be used, clopidogrel, and in acute coronary syndrome, apixaban or the other GP2B3A antagonist. So I think on this session we discussed the various drugs under the hematopoietic system. We discussed the thrombolytic therapy. We discussed the antiplatelet agent. We have discussed smaller details which are going to be objective and which is going to make you trained to solve a multiple choice question, as well as is going to help you to formulate your concept. And I hope you enjoyed this particular session. So we close this session by thanking you and giving you good wishes. Bye.